On behalf of Hetro Healthcare. My name is Rajamanikam, working as a Senior Sales Manager of Hetro Healthcare, Helian, a CNS division, and I'm looking after South. First of all, I'm thanking you all for joining us today, even on a Sunday. With a lot of commitment, you all joined to discuss on the topic, latest update on Parampinal, especially the pharmacokinetics and pharmacodynamics of Parampinal and indications and side effects of Parampinal. And as you know about Hetro, we have worldwide more than 126 countries operation, and we are a largest R&D wings having 360-degree solution provider. More than 25 years of experience and excellence in multiple therapies, currently present in 126 countries plus worldwide. More than 300 products across various therapeutic categories such as HIV, AIDS, oncology, cardiovascular, neurology, psychiatry, and new drug delivery system. Distinction of bringing 4 biosimilar products to the market, 36 plus state-of-art manufacturing facilities across the globe, pioneering in quality and innovation. Today with us, Dr. Vykunta Raju, HOD and Professor of Pediatric Neurology at Indira Gandhi Institute of Health, Bangalore. He is one of the authority in the field of pediatric neurology. He has done his DM Pediatric Neurology AIMS in New Delhi. His academic activities are numerous. I just name it few. 175 total publications he has done, and 75 peer review in the journals he has given, and 400 abstracts he presented in conferences, and he is author of a textbook on cerebral palsy, and he has contributed 25 chapters in other textbooks. Now over to you, sir. Today we are delighted to hear from you on the topic, latest update on Parampinal.
Good evening to all. So at the outset, thanks for giving the opportunity to moderate this session. So this is an update on Parampinal. So it is one of the rarest drug in anti-seizure medication. As you know, the unique mechanism of action and pharmacodynamics and pharmacokinetics, especially the long half-life and requiring only once daily dosage, and mechanism of action is a little different compared to many other drugs. So the drug of choice in many conditions, and side effects is also less severe side effects compared to other drugs. So today we'll be discussing on parampinol. So first talk is Dr. Tarishi. She is currently working as a pediatric neurologist at Narayana, Bangalore, and followed by Dr. Bhargavi. She is currently working as a pediatric neurologist in Manipal Hospital, World Airport. They'll be talking on parampinol. Thank you. So to the Dr. Tarishi.
Thank you very much, sir, for this opportunity, and thank you to the organizers and for all the viewers for taking time on Sunday evening to hear this talk. I'll just share my screen. Second. You can see the slides now? Yeah,
Yes,
so I'll be talking about the pharmacokinetics and dynamics of Parampinal. So Parampinal is not a new drug. Actually, it's been in the Indian market for the last 7-8 years. The good thing about is that in 2023, the patency was lost, and now we have more and more compounds, different brands at a cheaper cost. And knowing about the pharmacokinetics and dynamics will really help us use this very unique drug in more and more of our patients and help them with epilepsy. So let us begin to understand. So around 50 million people worldwide have epilepsy, and out of which 1 in 150 children are diagnosed with epilepsy in the first decade of life. Having drug refractory epilepsy early in life adds to the burden, causing neurocognitive delays, behavioral issues, adds to the financial burden to the families because of the cost of the medications, emotional burden, poor quality of life. They have problems in school, social stigma. Apart from that, the risk of premature death in these children with epilepsy is up to 3 times more than the normal population. Out of this whole population of patients with epilepsy, 70% of people can be seizure free if we have effective medications and we have proper access to the healthcare providers. With all that, today around 25% of pediatric patients are still drug resistant. So what we need is actually an ideal therapy which could provide us complete seizure freedom without producing any adverse effects or drug-drug interactions. So, why are we having so many new anti-seizure medications where, like, almost in the last 2 decades, 10, 15 drugs have been found? So, let us understand what are the problems which we had with the older anti-seizure medications. So, they, like our phenytoin, phenobarbital, and so many more, they had poor tolerability, increased adverse effect, increased drug-drug interactions. Multiple dosings were required, and this leads to poor compliance and treatment discontinuations. What we need in the newer drugs coming forward is a better efficacy, better seizure control, better pharmacokinetics profile so that they can be delivered rapidly and have OD dosing or extended release formulations, less adverse effects and less drug interactions. This would decrease the caregiver burden, improve the quality of life, and lesser adverse effects. When we talk about new drugs, so many drugs are there from 2000 onwards. But what are evolutionary drugs is which in which we improve the existing drugs. Like we have breveracetam, which is derived from leveracetam, same mechanism of action. So we are actually cloning the old one. Yes, we are working on the side effects and adverse effects have improved, but what we really need is a new mechanism of action. So revolutionary drugs are drugs that work with a novel mechanism of action, and perampanel is one such drug. Let us look at this graph. So we have had anti-seizure medication since 1857 to 1958 was the first generation of anti-seizure medication, starting from bromide and phenobarbital, which was introduced in 1912, which is still very much used in the clinical practice. But what was the problem in this first generation anti-seizure medication? So incomplete efficacy, there were uncomfortable pharmacokinetics, narrow therapeutic range, so many adverse effects, and this lead to treatment failure and also treatment discontinuation by the patients. Then we had the second generation anti-seizure medications coming from 1960 onwards, where we had our valproate, clobazam, clonazepam. These were definitely more safer, but at the same time more expensive, less drug interactions. But were they really more potent? They were equal effective as the older ones, and we did not achieve seizure freedom in most of our patients, complete seizure freedom in still one-third of the patients. And then we have 1980 onwards, the third generation anti-seizure medications. They are based on precision medicine. Some of them are very selective for the type of seizures, focal seizures, specific syndrome specific medications. Like we have stiripentol for Dravet syndrome, rufinamide for LGS. But along with that, they do have superior safety profile, but we are still lacking in the efficacy because and perampanel is one of the drugs from the third generation anti-seizure medication. So, this is a review from Therapeutic Advances in 2011, where they conclude that we really cannot say that all old AEDs are bad or all new AEDs are good. Definitely, the newer AEDs like levetiracetam, gabapentin, tigabalin, they do not have systemic side effects, and they do not work on, they do not disturb the pharmacokinetics by hepatic enzyme induction or inhibition, which helps us to use it at more drug combination. But there was a Senate trial which showed that the efficacy of levetiracetam versus lamotrigine and valproate, that is the third generation versus the second generation anti-seizure medication, still valproate was more cost effective and more clinically effective. So, but for the newer ones such as perampanel and others, we really don't have head-to-head comparison with other drugs. So we are struggling there, but the new ones have definitely helped us improve the pharmacokinetic burden. So when we treat our patients, the steps is with the first anti-seizure medication, we achieve at least 49% of seizure freedom. By adding the second and the third, 60 to 60% of the patients achieve seizure freedom, but still one third of the patients remain refractory. And then what we have to use is a rational polytherapy, a combination which would prove less, which would provide less adverse effects and more efficacy to these patients. And we have to remember, when we use drugs with a similar mechanism of action, it leads to the toxicity and adverse effects. And hence we need drugs with novel combinations with novel mechanism of action, so that we can actually add them to our so-called framework of rational polytherapy. So let us look at the drugs and their mechanism of action. The main mechanism of seizure generation is through the glutamate pathway, the postsynaptic neuron, excitation of the postsynaptic neuron by the glutamate. But if you look, the major chunk of anti-seizure medication acts on the presynaptic tunnel, the sodium channel blockers, phenytoin, lamotrigine, lacosamide, zonisamide, they're all acting on the presynaptic terminal. Then we have our brivaracetam, levetiracetam, which prevent the release of the neurotransmitter, again acting on the presynaptic terminal. And we have our benzodiazepine and barbiturates groups, which is acting on the postsynaptic, but they have an inhibitory response and indirect action on the glutamate. So none of these medications are actually directly acting on the glutamate pathway. Only two drugs, felbamate, which we know is not being used because of severe adverse effects, and the next is the perampanel, which was the only unique drug which was discovered as AMPA antagonist, and it is an inhibitor of the postsynaptic excitation. So we really need drugs with such as perampanel with novel mechanism of action, and hence perampanel was discovered in 2011 by an experiment on rodents. So knowing about this drug, it was first approved by EMA in July 2012 and by FDA in US in October 2012, and it was approved for use as an adjunctive therapy for treatment of partial onset seizures more than 12 years of age. In June 2015, the second indication was added for use in primary generalized seizures beyond 12 years of age. 2017, it was available in India under the name of Vycompa. And then 2018, the indication was expanded to children between 4 to 12 years of age, which really helped us use it more in our pediatric practice. And then 2023, now we have the patencies loss and more drugs. So cost has reduced and we can use more frequently by understanding its uses in different types of epilepsies. So this was a study for evaluation of perampanel in partial onset seizures. It was a randomized double blind trial, multicentric trial, phase 3 study. And it proved the efficacy of perampanel, significantly reducing seizures in partial onset seizures as an adjunctive therapy and increasing the responder rate versus placebo. Uh, and then 2015, its use was sorry, its use was extended to generalized seizures, idiopathic generalized epilepsy. There was phase 3, a pooled analysis for the phase 3 studies where they showed that perampanel increased the proportion of patients by 75% who achieve seizure freedom compared to placebo. So it's very important, a drug which is that effective, to understand its mechanism of action and its pharmacokinetics. So perampanel, as we can see in the name itself, we have AMPA. It is a non-competitive AMPA receptor antagonist. It directly influences the postsynaptic neuron, and thus it prevents the further spread of the neuronal excitation, and it helps to control seizures by stabilizing the neuron. So to understand this receptor, why are we looking at the AMPA more than NMDA? So AMPA is a fast excitatory receptor. The AMPA receptors at the postsynaptic terminal is mainly responsible for the epileptic synchronization and the spread of the seizure activity. Whereas the NMDA receptor is a slow component of the EPSP, and it is mainly involved in neuronal plasticity such as learning and memory. And so it becomes all the more important to block this AMPA receptor during a epileptic event or a seizure, because it will lead to reduced overstimulation of the neuron, and thus having its convulsant effect to prevent the further spread of the seizures. And in addition, they found that AMPA receptor antagonists may prevent neuronal cell death. And this is being, now being utilized to experiment use of perampanel in other indications such as neurodegenerative conditions beyond epilepsy. So a little bit more about its mechanisms, advantages. It is a non-competitive inhibitor. So what do you mean by non-competitive? So the binding site for perampanel on the AMPA receptor is different from the glutamate. So even if we have a high levels of glutamate, that is what happens during seizure, perampanel will still continue to bind to the AMPA receptor and prevent the opening of the channel. And thus it will still prevent to avoid the post-synaptic excitation. So that is a major advantage compared to other drugs. Also, an advantage of its mechanism of action is that because it is not acting through GABA, the negative effects on the cognition and then the visuospatial skill, which gets lost over a period of time in our patients with epilepsy and very, very important in children for their day-to-day activities and learning, that is not lost with perampanel. So coming to the pharmacokinetics, um, so it's apart from its mechanism of action, it has a unique pharmacokinetic as well. So it has complete absorption without any first pass metabolism, and the time to reach the peak concentration is just half an hour to 2.5 hours. This is very effective to get any response, even in conditions like status epilepticus. And apart from this, we also have to be cautious when we are using the drug, because peak side effects can happen within 2 hours, and that is why we prefer using perampanel at bedtime. It has 100% bio availability and 95% protein bound. Other thing is that the absorption of perampanel is not affected by food. It can be given with or without food. The extent of absorption doesn't change. The elimination T half of perampanel is very long, 105 hours. It takes around 2 to 3 weeks to achieve steady state concentration, but this prolonged half-life allows us to use it as a single OD dose, which is a major advantage in maintaining patient compliance. And also, if a patient misses a drug, the chances of having withdrawal seizures is very less, and we can immediately go back to the normal schedule. We don't need to retitrate it again if person has missed the dose, and we don't need to restart the medication from the beginning. Its metabolism is primarily by hepatic metabolism. So that here it brings us to the drug-drug interactions when we use it as drug combinations with other other anti-seizure medications. So because it is acting, its metabolism is by CYP3A. The CYP3A inducers such as carbamazepine, phenytoin, they increase the levels of perampanel by 2 to 3 fold. So they will increase its clearance, sorry. They increase the clearance of perampanel by 2 to 3 folds. That means that we have to give a higher dose, and we have to be cautious that how to that the effect is not gone. And with the enzyme inhibitors such as ketoconazole or valproate, the drug clearance is decreased. So this again needs caution because it can lead to side effects. When we use it with other benzodiazepine, barbiturates, which are seen as depressants, because perampanel's side effect is uh, sedation and dizziness, we have to be again cautious about the dose we are using it and tell the patients about it. With contraceptives, it reduces the level of levonorgestrel contraceptives, so making them less effective. So patients need to go for alternative methods. As such, although the other anti-seizure medications, the enzyme inhibitors and inducers have their effect on perampanel, perampanel itself does not affect the pharmacokinetics. That is, it does not have any impact on the clearance of other anti-seizure medications. Thus, using it with the non-enzyme inducers and inhibitors is very easy, and it is better to use it, safer to use it. In special conditions like pregnancy and lactations, there is not adequate data. Since it is hepatic metabolized, so it has to be cautiously used in hepatic impairment. We start with very low dose of 2 milligrams. Usually, in mild cases, we should not exceed more than 6 milligrams per day. In moderate, not to exceed more than 4 milligrams per day, and in severe, it is not recommended. In case of renal impairment, we can use it very safely. In moderate impairment, we do need a slow titration, going up the dose once in 2-3 weeks. Whereas in cases who have severe impairment and are on hemodialysis, it is not recommended because it is very severely protein bound. It is a Schedule 3 drug, has a potential to be abused and drug dependency. Hence, we don't recommend using it in adolescents or elderly who have underlying psychiatric side effects. Psychiatric symptoms. So there we need to have some caution. So dosing is 2 milligrams once daily at bedtime, which is quite easy. The with the increasing dose, the size of the tablet does not increase, which is very good for the patients. We usually start with 2 milligrams, and weekly or once in 2 to 3 weeks, we can increase it to 4, 6, 8, and maximum going up to 12 milligrams per day. Any missed dose, the patient can continue with the next dose as a normal schedule due to its long half-life. Also, it can be stopped abruptly because the plasma levels will automatically decline slowly. And another advantage is the dose and the titration is same in adults and children. So, perampanel actually shows efficacy across range of doses tried in clinical trial. This is a phase 3 study, randomized control trial, which shows that even doses of 4 and 8 milligrams had showed equal efficacy compared to 12 milligrams per day in reducing partial onset seizures. And also, it may be used across at the same dosing across all ages, gender, and ethnicity. So this we don't need to do any separate dosing for children. And it was seen at age. This study was done between for age group 2 to 12 years of age, and it was safe. There was no major adverse effects, and equal efficacy across all age groups. So to conclude, it's a novel mechanism of action makes it a good candidate for a rational polytherapy in patients with drug refractory epilepsy. Its long half-life allows us once daily dosing, improving the patient's compliance and convenience. And we need to look at future perspective of using this drug to establish its use as monotherapy, to use it as first line in so many other epilepsies. Ongoing research on new indications of perampanel, development of new formulations for improved patient compliance, and exploration of combination therapies, where we need to have more data on this, with which drugs there are better efficacy. So one such study, I'll leave with this broad spectrum review on use of perampanel in other indications beyond epilepsy, that it is because of being an AMPA receptor antagonist, it is being tried for cognitive impairment, autism, dementia, and other degenerative conditions. So this is still in trial phase, but I leave it to Dr. Bhargavi to expand on this and tell us how well we can use perampanel in our day-to-day practice in various different type of seizures and epilepsies in children. Thank you.
Thank you, Dr. Tarishi. Such a lucid presentation. So I will take questions later. I want to give some comments. So as the most important aspect of this drug is pharmacokinetic, the long half-life. That is one of the advantage. And pharmaco mechanism of action also different, so that you can combine with many of the other drugs. And the interaction, even though it is described, not so common interaction, not significant clinical interaction like enzyme inducer like compared to lamotrigine and other things. So mild moderate dose, not much clinical data is there to suggest dosage modification. Other important thing is syrup formulation is also available that can be used in small children. And even though there no data is there in children's per mg, but after start when you're starting 2 mg, especially small children, better to start 1 mg, even 0.5 mg, because many children lot of ataxia and drowsiness they may discontinue. So even though adult dose is prescribed, but better to start lower dose, especially small babies, and increase over a period of 1 to 2 weeks. And as I told, other advantage is not much interaction, mild hepatic and renal function. Only in severe cases you would be worried. And the maximum dose, even though they describe up to 12 grams, there is a study shows that not much difference after increasing further, like 6 and 8 and 12 was in adults also. So usually most of the times you'll get most benefit by 6 or 8, most of the studies also. Thank you. So Dr.
Okay.
Bhargavi will be telling about various indication and what are the problems you'll face in starting and how to monitor this patient.
Good evening, everyone. Am I audible?
Yes, ma'am, you are
Yes.
audible. Yes.
Thank you, organizers, and thank you, Vykunta Raju sir, for giving me this opportunity. Thank you, Tarishi, for that lucid presentation. Now we'll discuss about the indications and adverse effects of perampanel. So, broadly speaking, these are the guidelines. One is by US FDA and another is the European guidelines. So, basically, US FDA has approved perampanel as a monotherapy or an adjuvant therapy for focal seizures with or without secondary generalization in children with epilepsy more than 4 years of age as an adjuvant therapy in treatment of primary generalized tonic-clonic seizures more than 12 years of age. Whereas European guidelines, it has approved as an adjuvant therapy for focal seizures with or without generalization from 4 years of age and as an adjuvant therapy for primary generalized seizures after 7 years of age. So how do we get these data from? So whenever any drug is introduced into the market, the trials first happen in adults and then these trials are extrapolated in children. So these are this is one of the landmark study for perampanel to bring it to the market. Basically, it is a pooled analysis of 3 phase 3 trials where they were numbered as 304, 5, and 6. The patients were aged more than 12 years with focal onset seizures with or without secondary generalization who had failed at least 2 anti-epileptic drugs and had at least 5 seizures during the baseline period of 1 month. So 304 and 305 were high dose 8 mg and 12 mg and 306 the low dose 2 mg, 4 mg and 8 mg and 307 was a long-term extension study. So this is the pool data of the first 3 studies where they showed that the median change in the partial seizure frequency was greater with perampanel compared to placebo. And further, it was also dose dependent. 4 mg had 23%, whereas the 12 mg has 27% reduction in the partial seizure frequency. And the p-value was less than 0.01, which was statistically significant. And also 50% response rate, that is 50% reduction in the seizures were noted in 28% of the patients with 4 mg and 35% with 12 mg. Further, there was no significant adverse effects noted. And also, one more finding which these studies showed that the efficacy was lower when drug inducers like carbamazepine was administered. However, this does not lead to major drug interactions. Then coming to adverse effects were noted in a significant amount of the patients who were started on perampanel. But one thing which has to be noted here that though there were adverse effects which were noted, most of them were limited to CNS and most of them were mild in the form of dizziness, somnolence, and headache. And most of them were mild to moderate and they were self-limiting. Serious adverse effects were noted only in 8.9% of perampanel, whereas even in 5.4% of the placebo also. That means the side effects which are seen with perampanel, they are usually limited to CNS and it usually doesn't have major other systemic side effects. So to conclude these studies, they said that perampanel is a good option to be considered as an adjunctive treatment for refractory partial seizures. And also it provided relatively enough data to say that perampanel is well tolerated and safe. So with this, then there was another study, 307, where the patients from the first 3 studies were extrapolated to 307, where the primary objective was to evaluate long-term safety and tolerability, because the first 3 studies were only the short-term. This tried to evaluate the long-term safety and also the maintenance effect of perampanel for the treatment of refractory seizures. They also looked into the adverse effects and other laboratory parameters. And the secondary endpoint related to seizures were median change in the seizure frequency from the baseline and percentage of patient with more than 50% reduction. So in this study, the extent of exposure to perampanel, it was seen that 91% of the patient received and they were able to reach 10 or 12 mg of perampanel per day. Basically, it was a dose escalation study where 90% of the patient who were enrolled in the study were able to reach up till 10 mg. And at least 50% of them were able to retain perampanel for more than 1 year. And the median exposure was 51 weeks. That is almost up to a year. That means it is relatively well tolerated and has a good tolerability. The most common adverse effect noted even in this period of time were, again, it is mainly limited to CNS, dizziness, somnolence, headache. Systemic side effects were almost negligible. So with this, now we can say that perampanel mean dose of 10 mg had a favorable tolerability profile, and the retention rate was also good for a period of 1 year, and no new safety effects were noted. And also the improvement in seizure frequency and the responder rate were comparable with the short-term study. So with this, perampanel came into the market and was extensively used in refractory seizures as an adjuvant therapy, refractory focal seizures as an adjuvant therapy. And then there came many data from multiple parts of the world. One such from the Europe, where almost 2,000 people were included, where 95% had focal seizures, who were drug resistant, who were on multiple anti-seizure medications. And when perampanel was started, one can see that 48% had a good retention. They were able to maintain on perampanel for more than an year and without many side effects. And also it was noted that 1 year seizure freedom rate, meaning the seizure freedom at the end of 1 year, was 9.2%. This is one thing which is very special for perampanel, because the more the number of drugs the patient is on, that means the condition which we are dealing with is difficult, and one drug making so much difference, that is 9.2% seizure free rate, is a very good percentage for any new drug being added. Side effects were, again, though 50% of the participants had few adverse effects, but they were all again limited to CNS. A small group of patients, however, developed some behavioral and psychiatric side effects. So then came studies for generalized tonic-clonic seizures in idiopathic generalized epilepsy syndrome, where patients more than 12 years were enrolled, and it was a 13-week maintenance study. Here also there was a significant response in terms of reduction in the seizure frequency and also responder rate. So now we know that perampanel can be used in refractory focal seizures, can be used in idiopathic generalized seizures. Now, when to use, whether it can be used as a first add-on or a late add-on. So when this is a question, not only for perampanel, for any drug for that matter, when it is used as a first add-on, we may feel that, okay, it is doing better compared to late add-on, because the more the number of medications, the condition, if the condition requires more medications, it means that the condition which we are dealing with is a difficult one. So late add-on always has relatively less response compared to the first add-on, and perampanel is not an exception. So this study showed that it can be considered as an early add-on. However, this study had few limitations because of small sample size and retrospective study design. But however, one can always argue that perampanel can be considered as an early add-on because it has a unique mechanism of action. We have relatively good data on the long-term retention, its efficacy, tolerability, and ease of use because it is used only once daily. And also, there is no significant long-term side effects noted, no significant cognitive deficits noted, and also it has got a very low potential for drug interaction. So considering all this, so the Italian consensus clinical practice stated that perampanel can be used as a first add-on medication. So now, when it comes to drug interaction, perampanel has got some drug interaction. Some poor seizure control was observed when it was used with sodium channel blocker and other strong enzyme-inducing medications. However, it is not something which can be considered as a major drawback. We can adjust the dose of perampanel so that the efficacy is not compromised. And also, some of these studies showed that greater efficacy and better seizure control was noted when it is used in combination with valproate and levetiracetam, probably because of the drug interaction. However, no significant adverse effects or tolerability was noted. Then comes studies on perampanel monotherapy for treatment of multiple epilepsy syndromes. There are various studies, and perampanel is being used as monotherapy mostly in the adult population. Coming to pediatric population. So pediatric population is different in two aspects because the conditions which we are dealing with is heterogeneous, and mostly we deal with structural and genetic etiologies, and often we see drug resistant epilepsies in this category. And second thing is paucity of the drug trials. Any drug for that matter will first come into adult and then only into the pediatrics. So it is difficult to know what exactly happens in pediatric population. However, there are few landmark studies in pediatric population again, and this is one such study where children of 4 to 12-year age group who were not controlled with one or more medications, it again either focal or generalized seizures were included. So this study was a multi-center open label study which looked into the safety, tolerability, pharmacokinetics, and pharmacodynamics. 4 to 12 years of age group, focal or GTCS. And the patients were stratified by age and presence or absence of concomitant enzyme-inducing anti-seizure medications. So initially it was a pre-treatment phase where the children were continued on the same medication which they are taking. And then there was a treatment phase where the dose escalation was done, and then the maintenance phase. So totally 208 children were screened. However, 180 were enrolled and 146 were able to complete the study. Discontinuation was noted in around 34 children because of adverse effects in 14 children. One of the drawback of this study was the population. It was mostly the Japanese and the Caucasian race. We do not know whether this can be generalized to the rest of the world. The good thing about this study was that we can see that multiple seizures types were included in this study, like children had absence, myoclonic, GTC, atonic, and all of these. Here again, the mean dose of perampanel was 7 mg and median duration of exposure to perampanel was around 23 weeks. So the it's again the same thing. So coming to the side effects were again limited to CNS, somnolence, dizziness, and they also looked into the cognitive decline, whether perampanel long-term cognitive decline is there. So there was no significant decline in the cognitive function with the use of perampanel. Seizure outcome, one can see that it was effective. Median reduction in the seizure frequency was noted in 70% in generalized seizures and up to 40% in focal seizures. This is split up less than 7 years and more than 7 years. Almost equal efficacy and response rate was noted in all the age group of children. Coming to concomitant anti-seizure medication, there was no significant difference in the response rate when perampanel was used with enzyme-inducing medications or it was not used with these medications. So to conclude, this study showed that same perampanel dose can be used like in adults. It can be used as an adjuvant therapy in children with 4 to 12 years. It is generally safe and well tolerated, and it is effective regardless of seizure type, age, and enzyme-inducing antisocial medication status. So then came this study where children from 2 years to 12 years were included. There were two main take-home messages from this study. Here again, it showed that perampanel, even in small babies, can be used like in adults, need not be used as a body weight basis. And also, this study again emphasized that perampanel may have some short-term adverse effect. However, long-term adverse effects were very less, and it is relatively well tolerated. So then there are some ongoing studies where perampanel is being tried in children from 1 to 24 months. And coming to specific epilepsy syndrome, long-term efficacy of perampanel has been studied in LGS, where up to 41% response rate has been seen. And however, this is almost similar to other medications, but we need head-on trials in such reflex epilepsy syndromes to really show that whether perampanel is really better than other medications. And then there are various studies for perampanel in myoclonic seizures, PME syndromes, and also there are studies coming up saying that perampanel is helpful in epileptic spasms and also in absence seizures. Further, this is one retrospective study where perampanel was studied in genetic epilepsy, and perampanel demonstrated a high safety and efficacy in some of the genetic epilepsies like SCN1A, GNAVO, and PCDH19, probably related to the novel mechanism of action related to glutamate transmission. So these are some of the real-world experience. The PERMIT study, which showed 50% response rate of almost 58% by 12 months, and relatively good safety profile. This is another study which is a phase 4 study of perampanel, which again showed similar efficacy rate and tolerability. So coming to in clinical practice, there are some guidelines given by expert opinion from Asia. So where to use perampanel can be used as an initial therapy in focal seizures. It can be used as an add-on therapy in LGS, Dravet, basically any refractory epilepsy of childhood. How to start? Go low, start with a low dose and then go slow. Ideally, less than 1 mg or 2 mg on alternate days can be used. Less than 1 year children, better to use 0.5 mg and slowly titrate. In cases like fires and status epilepticus, one can start with 2 mg per day. Titrate very slowly once every 2 weeks, depending on the body weight. Less than 20 kg, go slow, 1 mg increment. 20 to 30 kg, 1 to 2 mg increment. More than 30 kg, 2 mg increment can be done every 2 weeks. Maintenance, keep it 4 to 6 mg. And further, when we are trying to increase perampanel more than 6 mg, we have to be more cautious in children. How to use? Some side effects are noted, like somnolence can be there. So if there is any serious side effects like history of psychiatric illness in the family, that has to be screened. But however, it is relatively well tolerated. Monitor for hepatic function. Mild to moderate, it's okay. But if it is severe, then we have to take a call. Concomitant medications, if we are using enzyme-inducing drugs, then the dose of perampanel can be increased up to 12, sometimes even up to 14 to 16 mg. Then how to prevent and manage the adverse effects? Use a low starting dose with slow titration. This is one of the key factor. Most of the side effects in clinical practice we see are mainly when we start with the high dose or we titrate very fast. So we have to start slow and go slow. Then monitor closely, especially when we are using more than 6 mg. And psychiatric and behavioral side effects may be there in the initial few weeks, but if we are seeing significant side effects, then we have to either maintain at the same dose or reduce the dose a little bit. And parents have to be counseled regarding these side effects. So to conclude, perampanel is a well-tolerated anti-seizure medication. It has a broad spectrum of efficacy with good tolerability. Slow titration is recommended. More than 6 to 8 mg in children, be cautious. Most common side effects are dizziness and somnolence. And FDA has given a black box warning for severe behavioral side effects and homicidal tendencies. Thank you.
Thanks, Dr. Bhargavi, for overall update and how to start and how to titrate and various indication, recent data on perampanel in children. So main important points is it is a broad spectrum drug. So most of the drugs and newer drugs in children usually will be careful, but in the perampanel is one of the drug where you can use most of the epilepsy syndrome and data also showing you can use. That is the most one of the advantages. And regarding the side effects, only thing is you can prevent like drowsiness and ataxia is the one that mostly parents they will discontinue. To limit that, better to start with a very low dosage. But regarding the psychiatric problem, that is one of the biggest challenge you'll face. Most of the patient, even though if we start difficult to prevent, some of them have a severe behavioral problem, need to be discontinued also. That is one of the problem we will face. So, any other questions they can ask?
Sir, there are panel members available, sir, and they can ask question and and we can go ahead with that.
Any role of one question is there any role of parental and cervical dystonia in children? Role of parental in cervical dystonia. I don't think any direct role is there as such. You are not using for dystonia. Maybe comorbid co-occurrence condition can be a useful thing. So other questions are that second question: how to predict and manage parental side effects? This you are already discussed in the talk. How does parental affect cognitive function and
these are all
behavior?
online questions, sir. Online things we are just sharing to you.
Yeah.
And Bhargavi, ma'am, we can close the presentation, ma'am.
Some of the questions asked are what are the most common side effects of perampanel? How can they be managed? So you are already discussed that. So most common is side effects is sedation, drowsiness, and behavioral side effects that can be managed with starting with a very low dosage. And if side effects occur after increasing, it's better to decrease the dosage that you already discussed. How does perampanel impact the risk of seizures in patients with history of status epilepticus? So, Bhargav, you want to answer? How does parental impact the risk of seizures in patients with status epilepticus? And simultaneously, can parental can be used in combination with other anti-epileptic drugs? If so, what are the benefits and risks? How does parental affect cognitive function behavior in children with epilepsy? And there any other studies? So, you want to ask something about status epilepticus and parental?
Perampanel can be used in status epilepticus. We can start with 2 mg and titrate faster if required. And it practically it has shown a good response because of its novel mechanism of action. Definitely, we can consider in refractory status as an early add-on.
Yeah, that is one of the advantage because compared to all other medicine currently using is most of the times a different mechanism of action. That is one of the advantage you can use perampanel. Some of them recommend the loading dose of up to 8 mg also. So there is no exact recommendation. So loading dose, then you can try. Only advantage mechanism of action is different. Disadvantage, there is no currently IV formulations are available. That is one of the advantage. So the drug interaction you are already discussed and you are already other question. What are the optimal dosing regimen for perampanel in different patient populations such as children, elderly, adults? Children, I think you are already discussed. So you want to add anything in adults? I think
again the same, sir.
Yeah.
2 mg in adults up to 16 mg has been used, but in children, when we are going beyond 6 mg, we have to be a bit more careful and have to go slow. And for infants, though it is used as an off-label, we can start with low dose like 0.5 mg or 1 mg or 2 mg on alternate day for the infants.
What are the benefits and limitation of using perampanel for treating any specific type of epilepsy that you are already discussed? You want to ask any? You want to add anything extra? So this you are already discussed. It is useful in many of the epilepsy syndrome as it is a broad spectrum drugs. Even though it is recommended for focal seizures and focal secondary generalization, but it is shown that it is, can be used in myoclonic epilepsy, especially most of the PMEs. Even though they are refractory, most of them will respond very well, including absence epilepsy. And even though not much data is there, and infantile spasms, epileptic spasms also shows there is significant response. When there is no option of after exhausted with all currently approved medications, so after discussing parent, you can consider, you can see that some improvement you can see with this drug. How we differentiate levetiracetam, lacosamide, and panampel in focal onset seizures and focal with secondary generalization and secondary generalized seizures? So any difference for perampanel with respect to levetiracetam, lacosamide in various types of seizures they're asking?
At least in the clinical practice, we are not using perampanel as monotherapy in children with IgE. US FDA has approved as a monotherapy for more than 4 years, but in clinical practice, we are not often using perampanel as monotherapy because dose escalation is one issue. And we have better drugs like levetiracetam and brivaracetam, which can be used as a first medication.
So that we were already discussed, levetiracetam, as you know, that is approved after 1 month also as a monotherapy, even newborn period also, many of the trials are there. So it is easy to use and more formulations are available and it is easy to use. The lacosamide also, it is useful, especially if you think of sodium channelopathies. When you are doubtful about the old drugs like carbamazepine, oxcarbazepine, where it is one of the drug you can choose, like when confusion whether it will poke myoclonic seizures can worsen. That time, if you're confusion about sodium channelopathy versus other myoclonic epilepsy where lacosamide can be used, that is one of the advantage. And main advantage, perampanel is a broad spectrum drug compared to lacosamide, so you can use if the many types of seizure, mixed seizures are there, especially in the older children. The side effects wise, the lacosamide has maybe comparatively less side effects compared to perampanel and levetiracetam, most probably. Okay.
Okay,
So
fair
any
enough,
other
sir.
questions?
Sir, has a like just the question came in the mind by this question. Has Madam also said when we say perampanel and it generally offers when there is a chances of dose missing, like working class of patient. So if they miss
Yeah,
their
see, so perampanel half-life is 105 hours. So usually we can give once in 3-4 days also, but ideally it is not recommended because if you tell that the parents, most of the chance they will miss also.
right,
So you
right,
can give once in 2-3 days. That is not as one of the advantage, but practically we will not advise because if you tell parents to use once in 3-4 days, lot of misunderstanding and also they may miss more chances unless advising daily. So if you use 1 or 2 days, usually not happens, but you should be careful also when you are discontinued. There are, they may get seizures after 1 week also. So may not be feeling that after missing also nothing will happen. Parents feel that drug is not effective after missing also child not got any seizure. That also they should you should explain to them so that they may not get breakthrough seizures like up to 2 to 3 days also. They should not believe that after discontinuation of drugs, this child didn't get any seizure, so you can discontinue. That also they should counsel.
okay. Fair enough, sir. Cleared. So all the questions been answered.
Yeah, okay.
If there is no question, sir, with your conclusion remarks, we can
Yeah.
close, sir. Yes.
Yeah, thanks, Dr. Tarishi and Dr. Bhargavi also. So the in detailed discussion of basics and also various clinical uses. So as already discussed, one of the useful drug, the most advantages is it is a broad spectrum drug and it can be long half-life. Drug interaction is less. So one of the drug currently, the newer generation, it can be used when you seen a case of drug-resistant epilepsy compared to currently available newer generation drugs. Thank you.
Thank you so much.
Thank
Yeah,
you, sir.
so much.
Thank you, both the speakers and moderator, sir, and all the viewers, sir. Even in a Sunday, there are more than 100 participants logged in, and it is really overwhelming. And they are really interested in pediatric neurology and this new drug, Parampinal, and it has got an Indian experience of last 2 years. They were really interested in that. It shows, sir. Thank you very much for all your efforts and the participants' efforts. Thank you so much on behalf of Hetro Healthcare.
Thank you. Thank
Yeah,
you.
thank you so much, Bhargavi ma'am and Tarishi ma'am. And thank you so much, sir.
Thank you.
Thank you.
Thank you.
Thank you, Raja Madikam, sir.
Yeah, welcome.
Srinivasan, sir.
Srinivas Rao, sir, we can close the live.
Okay.
Yes.
And thank you so much, sir, for your presence in this webinar.
Thank you, sir. Thank you very much.
So we can conclude now. Okay.
Yeah.
Yeah, Raja Madikam, sir. Thank you for
Yeah,
your.
thank you. Thank you so much. Yeah.
Hi.
Fine.
Yeah. Chalo. Bye.